My name is Ashu Sabharwal. I'm a faculty here at Rice in Electrical and Computer Engineering Department, and also helping set up a new initiative at Rice on digital health. So I'm really looking forward to this session, and thanks, Rebecca, for inviting me to introduce the speakers. There will be three talks, three excellent talks. Let's see, how do I? Yeah. By three esteemed speakers with tons of experience. I had a chance to talk to one of them just now. The first talk will be on the next generation solutions, AI-augmented devices and tools for global health by Dr. Ranjani Ramamurthy from Global Health Labs. Ranjani is a health data and health AI leader with 25 plus years of career spanning executive roles, entrepreneurship, and clinical research. And very unique background. I just learned, that she is both an MD and a software engineer. Even these days, it's impossible to find such background. So yeah, cool. She was telling. I was listening to her story. Very inspiring. She spent the past decade at the intersection of technology, data, and medicine in commercial sector. Currently, she is serving as a vice president at Global Health Labs, a nonprofit dedicated to driving innovation in devices and tools, especially targeting low and middle income countries. The second talk will be Scaling Newborn Care Through Clinical Decision Support Software by Dr. Josh Bress from NoviGuide. Josh is a pediatrician whose primary focus is care of neonates. He graduated from Vanderbilt, I won't say the year, but I realize I'm older than him, and completed his pediatric residency in the University of California, San Francisco. Since 2011, he lived in Eastern Congo, delivering pediatric and neonatal care alongside Congolese colleagues. His passion is working and learning from frontline clinicians. So I'm really looking forward to learning how things are at the front lines. And the last talk will be on the development of an ethically sound, robust algorithm for cervical cancer screening and diagnosis by Professor Nimmi Ramanujam from Duke Biomedical Engineering. Really, really important topic, especially I'm looking forward to the keyword ethically sound. I think we'll all learn a lot today. Ramanujam addresses pressing challenges in women's cancer, specifically cervical and breast cancer. Creating technologies that transform complex diagnostic instruments into accessible, affordable, and appropriate solutions. Several of her products are now being used in many countries, US, Latin America, and Africa. So no wonder she is internationally recognized for her contributions with several major awards, including the Technical Field Award from IEEE Biomedical Society and Social Impact Abbey Award. She's a Fulbright Scholar, member of National Academy of Inventors, and a fellow of many, many professional societies. So, I want to take one last minute to say a few words on a new initiative at Rice. So as you all know, Rice is right across the world's biggest med center. And a few years ago, with the rise of digital technologies, we started putting together an investment around the idea of digital health. So this is now called Rice Digital Health Initiative, and Rice has made significant investments in it, multiple faculty lines, 10,000 plus square feet of lab space in this building, which is being built, almost ready to go. And we have a rapidly growing faculty, lots of young faces on this slide. In fact, you heard from one of them yesterday. Julianne is here. She's right there. There you go. So yeah. We have amazing junior faculty, full of energy, and looking for new partnerships. So please feel free to connect to them. They are on the website, Digital Health Initiative website. Feel free to contact me, and I'm happy to connect you all. And then in the coming months, we will also be announcing several initiatives, which I hope complement all the work you do with medical partners, enabling clinical trials and development and deployment in scale. So happy to feel free to reach out, and I'm happy to connect folks with the right people.
Good morning, and I'm actually delighted to be, can you hear me? Yeah, I'm delighted to be here. Thank you very much for that introduction, Ashu, and thank you for the invitation, Rebecca. So I'm Ranjani Ramamurthy. I serve as Vice President of Program Innovation at Global Health Labs, which is based in Seattle. A little bit about us. We are fully funded by Gates Ventures, and our focus is on innovation in primary healthcare tools and equipment. And our primary focus area is India. We also do work in Kenya. I'm going to be talking about initiatives there in both those countries in my talk. And we work in collaboration with the Gates Foundation, but are independent from the Gates Foundation. And today I'm going to be talking about the role of AI in our product investments at GHL. So just wanted to start with this because this is at the heart of a lot of the work that we do, which is about maximizing impact and really understanding how technology can be a catalyst, but that it's a tool, and how it can actually, catalyze innovation, but really think about how we use technology in solving important clinical problems. So, when I was talking to Rebecca when she gave me this invitation, I was telling her that, Global Health Labs actually invests in tools and equipment in primary care. We do have, as we know, 10 to 20% of patients who actually come to a primary care clinic are pregnant. And so ANC care is an area of focus for us. And so we actually think a lot about innovations to actually help moms be healthy so that they can deliver healthy babies. And so I just wanted to kind of share this statistic out here. All of us are familiar with this on maternal mortality ratios between 85 and 2020. Both India and Kenya have made substantial progress, but we're not yet at the SDG goals that we would like to get to in 2030. India has actually come down from 650 maternal deaths in 1985 to a little over 100 now. And that got us thinking about, how do you help moms be healthier during pregnancy? How do you intervene earlier? And what's the best way to go about that? And there is no one magic bullet. We all know that. It has to be a toolkit of solutions. And nurses and frontline caregivers are usually the first people to know when a woman gets pregnant. She usually knows this well before the mom even visits any primary care facility. So that got us thinking about, hey, where are the opportunities here to intervene earlier? So I then looked at, clicked a little too far. There we go. So, we then started looking at, how often a mom actually sees a qualified health professional. And the numbers were actually quite encouraging. The WHO and, in India, for example, there's a recommendation that a woman sees a healthcare professional, a pregnant mom sees a healthcare professional at least 4 times during the course of her pregnancy. And we see in these statistics that in the 2 countries I'm going to be talking about in terms of our investments, anywhere from 80 to 95% of pregnant moms do get to see a qualified, skilled health personnel at least once during her pregnancy. We'd like it to be more, but at least this is a start and an opportunity. This is one of those things where, I gave the slides in a couple of days earlier, and I wished I could have edited this line, but what we see this is, is there an opportunity to kind of improve on this interaction, and how do we do that? And one of the things that we realized was, especially in India and some of the places that I've been talking with, it's difficult for moms to actually come into primary care clinics, right? So there's a huge push to take more care to the patient, to take care near patient. And so at Global Health Labs, we just decided that one of the big focus areas for us actually was to empower nurses. I just loved it when Rebecca talked about it on the previous panel. I was like, oh, good. We're on the same track. So we really want to use technology to democratize screening and referral tools for nurses. And I'll talk to you about some of the investments that we're making. And one of the most important things that we have learned is that, even if you are embedding technology, disruption is not a really good word. Technologists use that a lot, and it's not a very nice word. You have to kind of work with the system. You have to integrate into existing workflows and use technology to augment and amplify. In my previous life, I was at Microsoft Healthcare, and we built an AI-assisted scribe for physicians. And I used to say this all the time, which is AI can augment and amplify, but I'm more interested in the third A, which is I don't want to annoy. So that's kind of, the theme that you bring in here too, which is let's use technology thoughtfully, ethically, and mindfully. And so we really started thinking about, there's been so much around AI and ML helping in healthcare. So how could we use AI and ML? And this is a key concept I would love to kind of introduce to you that Global Health Labs is running with a couple of our collaborators. So a nurse has a tool. As I said, we are trying to empower nurses with triage tools so that she can, identify moms who need to be referred to higher levels of care. So the key concept is this: what if mobile measures or mobile clinical measurements that a nurse takes could be a surrogate for gold standard tests that are only available in a central diagnostics lab or higher? So let me give you an example in cardiovascular disease. This is something where we already have some very promising preliminary results where, if you have patients with diabetes, you could perhaps detect silent heart attacks with a 1 to 3 lead ECG, just a mobile ECG, if you have the appropriate AI and ML algorithm that maps from echocardiogram data to a 1 to 3 lead ECG. That's the fundamental concept. And you could kind of expand on this. And I've just put a few things here as illustrative examples. So saying the same thing in words, we actually want to use the tools that a nurse already has or that she could be trained to use and use this as surrogate for more expensive tests. And we know that we'll have to add a few sensors or devices to her toolkit, but we're being mindful about keeping them mobile and not expensive. Like really, really thinking about cost. And I'll speak to that shortly. And of course, being that this is about doing something that is not generally done as standard of care, how often, does a person get data collected on them, which is both a gold standard as well as a mobile measure? That doesn't happen at standard of care, correct? So this needs prospective data collected. So you need gold standard tests and mobile tests both collected from the same patient. And I'll give you a couple of examples, even with the AI-assisted ultrasound, where our lab's building an algorithm for that. It is painstaking, and you have to collect the data to actually be able to do this. And again, an AI algorithm by itself is not going to quite work. So you have to wrap it into a concept called what we call as product packages. And it has 3 parts. One is devices and diagnostics that could be available to the nurse. So I just gave you the example of a 1 to 3 lead ECG. It could be a blood pressure cuff. It could be urinalysis strips, a hemoglobinometer, what have you. Anything that is available to her, either when she's going door to door or in a mobile medical unit, but simple stuff, not stuff from a central diagnostics lab. Could even be an RDT. We have one example of that, a rapid diagnostic test. Then you have an AI-ML algorithm that actually takes some of this data. Let's say I want to find out if a person has had a silent heart attack. Maybe I need some other demographic information input into this algorithm, right? Something like, okay, the patient's age or something else. And then a software wrapper around this. It's all about, good intuitive user experiences that guides the clinician, the nurse, through this journey, instruments this entire process, and collects data responsibly in a secure manner. So that's what I call a software wrapper. So these product packages are what we're investing in, and I'm going to be talking about 2 product packages that GHL is investing in. And why is it a product package? Again, disruption's not a good thing. You need to integrate with the workflow. In both cases, we are integrating into existing nurse workflows. And why are we using AI and ML like this? Again, there's no single magic bullet for any of this. Even if you want to build a risk stratification algorithm, it's not going to be one piece of data. You're going to need multimodal data. You're going to need measurements from multiple devices. And we also know that a lot of this is about timely, accurate referral. You need to make it simple. This is not about, ML algorithms with area under the curve and all of that. It's about, a red light and a green light, refer or don't refer. And you should be able to calibrate that appropriately, correct? And you need to know to enable follow-up care. I've been in clinic in the US and spent a lot of time in India too. Sometimes patients just don't know what next steps are. You need to be very clear about what the next step is. Which brings me to the 2 product investments with AI on the edge. The first one is near patient, and it is to address vertical transmission of HIV, hepatitis B, and syphilis. That's one investment that we're making. The second one is at point of care to address preterm labor. So the first one on reducing vertical transmission. So we have a lot of numbers here, but let me just tell you where the inspiration for this came from. Of course, we know that vertical transmission is immensely, it's sad, it's something that is extremely treatable. And earlier the better, the first trimester of pregnancy, all of us moms here in the United States know that we have had all of these tests done when we got pregnant with our babies here. It's not the standard. And in a country like India and in Kenya, moms don't really come into primary care in their first trimester of pregnancy. We know that too. But let me give you a little bit of a story on, where the inspiration for this came from. Yes, these are goals of the government, of the WHO, et cetera. But really, a couple of my colleagues and I were in India a few months back in a very tribal and rural area in Tamil Nadu, in a southern state in India. And the rates of syphilis there can be upwards of 8% because the men go out as, migrant labor, and they come back into their communities with the infections. And there's no, it's 3.5 hours from the city. There's no central diagnostics lab. And as the doctor was telling me, she takes a mobile unit into the village once a month. Every day of the week, she's going to a different village. So she goes in once a month, and she said, I have to get blood samples from there, take it back in my van. I have to get back by the evening because there are large mammals. I need to get back to the city. And takes her maybe a week to 10 days to actually get test results done, which then have to be communicated to the community worker. I don't need to explain this. Everybody here knows this data. So she said, addressing vertical transmission is important. HIV rates in this particular village is not high, but syphilis is. And Hep B dose administration is challenging. Everyone here knows this. So what does she do right now? All pregnant women are referred, blood tests are taken, and then if the patient is positive, you do the ART, penicillin or tenofovir. The third one, I have a star on it, is because it's because of viral load. I'm just being a little... So let's go to the AI-ML mapping. So RDTs are a good surrogate for serology. And we actually have found a couple of rapid diagnostic tests available in India, which cost about 66 rupees for the 3 tests. So that's around 80 cents. So we found one for HIV and syphilis and the other one for hepatitis B. So we're just using it as a screening test, not a diagnostic. And the AI-ML mapping is actually about a digital reader. So this is how the product package looks like. We have a digital reader for the rapid diagnostic tests. And this is so that, the training, what is being purchased, nurses don't have a say in what's being purchased. So let's say a new RDT is purchased, or there's a new multiplex test. There's no amount of training that has to happen to be able to accurately read it. So there's been, studies that have been already done on this to show that it's actually quite valuable. And especially in the kinds of areas that we are, planning implementation, the doctors there tell us that this could be pretty useful, because you want to kind of narrow the funnel of people whose samples you actually take and the ones you actually have to refer, because it's 500 rupees, to, go to a clinic, and that's not their priority. So, so this is one that we're doing. So we have started studying baseline rates, engagement with the healthcare system, and the whole idea is not so much about this digital reader. This is getting patients to engage with the health system earlier in their pregnancy journey. And we have a set of other products that we are sensors that we're adding to this mix here, starting with vertical transmission. But for example, gestational diabetes rates in India are very high. In Tamil Nadu, they're about 17%. In other states in India, it can be upwards of 35%. And the current standard of care is to take a spot glucose test. They don't do OGTT. They don't do oral glucose tolerance tests in India. And we know that hemoglobin A1C is not a very good indicator. There are many physicians in the audience. You know what I'm talking about. So we're actually adding some sensors to this mix. So this is the base product package for screening. And all around, it's all going to be screening. It's not going to be diagnostic. It's about how do you narrow the funnel? How do you send the right patients into primary care or higher? So that's product package number one. We have a set of different investments that we're going to be putting into the base product package, which kind of brings me to number two, which is AI at point of care, which is about reducing preterm birth. So I met a few folks from Kenya here, so you probably know these stats better. These are just, some things that we've been thinking about. We know that there are a lot of high-risk pregnancies, and not too many moms actually get an ultrasound in Kenya. This is not specific to Kenya. I'm just talking about it because we're doing some of our clinical insights. We're taking our clinical insights from Kenya and are going to do some validation there. This is true in parts of India. It's true in many other low and middle income countries. And ultrasounds can help a lot. All of us know that gestational age determination is super helpful. That helps you know whether a mom's going to be getting into, having preterm birth or not. Later on in pregnancy, it's useful. Ultrasounds can be used to detect complications like preeclampsia, intrauterine growth retardation, so many other things. But moms just don't have it. And Kenya has 500 OBGYNs. I tried to get data on, sonographers who are qualified for this, but, it's 500 OBGYNs for about 28 million women. And so again, let's use AI to democratize ultrasound use. This is again about empowering nurses. Ultrasounds are expensive. They're used by specialists. They are not in primary healthcare facilities. They're usually a little higher. In some parts of India, they're taking it. In India, they're actually taking it into the communities, but these are in some states, not all over. In Tamil Nadu, they do this, but not in every state. And so there comes, and we all, I don't know if there's any radiologist here in our audience, but I know that when I was in medical school, in the internships that I did, it took me some weeks to actually look at the imaging to know what it is that I was looking at. Ultrasound measurements on fetal measurements require a lot of training, many, many hundreds of hours of training and continuing education. And, nurses can't be expected, nurses are not trained to do this. There comes in the blind sweep ultrasound. It's not a new idea, but this is actually being productized. This is being done with partnering with the Gates Foundation. So a blind sweep ultrasound is exactly this. Think of it as a handheld mobile ultrasound device that can be used by a nurse or a nurse midwife. She's not looking for specific anatomical markers. What she does is 3 vertical sweeps and 3 horizontal sweeps in order to get some parameters about the baby, specifically gestational age. So the Gates Foundation has collected data from North Carolina as well as from Zambia, and the data collection continues. And this is actually aligning with what I talked about before, which is you need gold standard data, which is ultrasound data that's collected, when a technician or an OBGYN is doing the procedure, and you need blind sweep data. You need someone who's a nurse midwife to actually do the blind sweep data collection so that you can actually build these algorithms. And this is what has happened. And this data is actually in the public domain, and multiple companies have actually taken this data. I'm really happy to share that Global Health Labs has actually created an algorithm for this and we're working with manufacturers in China to actually put it into a handheld device that can be used at point of care. And we have already had really good success with gestational age estimation. And the interesting thing is not only is it good, of course, gestational age is much more accurate earlier on in pregnancy, correct? But what we found is that gestational age is pretty good even later on as compared to biometric measurements. So it doesn't, when you actually look at the curve, it doesn't degrade as fast. And if there's the doctors in the audience, you know that some of these things, a physician can figure out, like fetal presentation, but it'd be good to have a device that just tells you, hey, it's cephalic or non-cephalic, and if there's multiple gestation. Some of the other things are harder to do, like IUGR and umbilical blood flow, and the reason for that is data. If you don't have data, you're not going to be able to build these AI algorithms with the level of sensitivity that you need. And so, as I said, data collection continues. So we already have some good results with gestational age estimation, fetal presentation, multiple gestations, so on and so forth. And it's very interesting, because you kind of guide nurses. It's about 8 hours of training to be able to do the blind sweep ultrasound, okay, for a nurse or a nurse midwife. You tell them, well, it's 3 horizontal and 3 vertical. But sometimes you may see something interesting and you just kind of stop and say, oh, and you go down and up. And that doesn't seem to actually affect the algorithmic correctness. So which is interesting too. So true deep learning for doing this kind of work. And we know that this is going to be one of multiple parameters we're going to have to collect. Because think about AI on the edge where you've got this algorithm on an ultrasound. It's going to tell you gestation, but that's not going to give you a risk stratification on red versus green. Do I triage to a higher level of care, or does she continue with care in the community? So we know that something like this will have to ultimately be a part of a product package. We're not there yet. We're still building the algorithms and collecting the data. We know that it will have to be a mix of data from an AI ultrasound or a blood pressure cuff or so on and so forth to build a risk stratification algorithm wrapped in a product package that then gives the nurse a sick versus not sick decision. So, and the idea again is if you had an AI-augmented workflow, you only refer those women that you're worried about. And of course, you have to calibrate it. You have to calibrate it for, usually it's for, sensitivity. And it depends upon the community, and what the system can afford, which brings me to another very important point of something that we're thinking about in all of these near patient and point of care packages, which is cost effectiveness and cost benefit analysis is being done and baked into right from the beginning. We are collecting economic data right from the beginning, not bolting it on later on, because an important output of this exercise is not only saying, okay, does this product package work or not, whether it's vertical transmission or investments into addressing preterm birth, it's also where does it become cost effective and what's the business model around it. I'm sorry, I guess thank you. I am going to run and finish. Thankfully, I'm at my last slide. The most important thing is that we're training it for the people who have to use it. Thank you so much.
I'm Anna Marie from the Newborn Foundation and Bloom Standard. Thanks for this great presentation. We've actually had the good fortune to be working a little bit with Global Health Labs on some of the algorithms and providing data against kind of a different kind of novel device that's doing automated sweeps on to sort of simulating your 6-week protocol, but in an autonomous way. But what I'm really more interested in is how you talked about bundling data and looking at multiple data points on the algorithm side. So we do have a poster over here, and I'll talk a little bit about it tomorrow, but because I spent 10 years working on pulse oximetry implementation for newborns, I care very deeply about this data point, and a lot of our work in PEDS is merging not just the autonomous ultrasound scanning results on pediatric patients with that data, and we're trying to figure out how to do this, or what are the secondary data points that would be most useful for algorithm development on our very early feasibility in these maternal ultrasound scans. So pulse ox seems a logical one, since we're used to doing that, and that might be helpful for the data for the mothers as well. But as we're working with Mayo Clinic right now for the first time outside of our own prospective data sets to help accelerate that, I'd love to go back to them, and maybe with the help of Global Health Labs, think about what additional things we can be looking for at the point of care to help augment that ultrasound, that early first and second trimester ultrasound screening data. So thank you. Sorry, I rambled off on a tangent there, but this is something we're still learning about because our entire focus up until now has been on newborns and peds. So thank you.
Thank you so much. Yeah.
What is the reaction of radiologists to the point of care ultrasound? And maybe another one is, I like this democratization concept, and maybe also deprofessionalization. So do you see this AI-enabled ultrasound as part of self-care in the future?
That's a great question. So the first one, in our field visits, it's been consistently a positive response to using AI to democratize screening tools. We're very clear about it being screening and not a diagnostic, because these are going to be put into the hands of nurses and nurse midwives and community nurses, correct? So it's been positive because we think about this as a funnel, right? If you want to get the sickest patients into primary care, because even then doctors are dealing with maybe 40 to 150 patients within a 3-hour shift. So if we could ensure that the sickest patients are getting to the doctor, that would be a good thing. So short answer is, I think the reaction has been positive. We haven't gotten to thinking about whether there is certification for this. We are in the product development stage, and we have to go through all of the regulatory approval. We already have a timeline for that, and then go to market. So I don't know if there's going to be that's a great question that I don't have an answer to.
Thank you.
Thank you.
Thanks for a great talk. I had a question about whether or not you've considered on your ultrasound thinking about addressing needs in low resource settings in the United States at the same time. I heard a presentation last week by someone who works at the Texas-Mexico border, and she was talking about how women who live in Texas got prenatal care, had a 20-week ultrasound, but then because the practice was small, the sonographer wasn't experienced, things like hypoplastic left heart are being missed. Mm-hmm. with really tragic outcomes. So I'm just wondering if there's an opportunity early to think about the intersection between those. I'd love to hear your thoughts.
Yeah, thank you, Rebecca. I think it's been brought up, but right now our area of focus is actually using manufacturing partners with a focus on Africa. This definitely, we have some other investments actually in cardiovascular disease detection, et cetera, for patients with hypertension and diabetes. And the first remark we got on that investment too was about how applicable it would be in rural communities in the United States. I think at this time, we are just making sure that the product package idea actually works, is ethically built, and has the right clinical validation. But it has been brought up. It's not yet on our roadmap. Yeah. Yeah.
Hello. Thank you very much for the presentation. I wanted to know what are some of the considerations you've put into patient privacy and AI for the HIV testing and screening in low resource countries like India and Africa, some of the sub-Saharan countries. Yeah, so privacy and also confidentiality with AI.
Yeah.
Thank you.
Thank you so much. Thanks for asking that question. I think data privacy and security is top of mind for us. So first of all, our algorithms are completely built on de-identified data. So using the international standards, which is either safe harbor or expert determination, we definitely do that. All the data is stored in, and you bring up a great point because I'm involved in multiple data consortiums outside of my work at Global Health Labs. And one of the big asks is always that data needs to reside in the country in which it's collected and data centers in the country with the highest levels of security. So we are ensuring that, in terms of the security and compliance, et cetera. So it's top of our mind for us. None of the data is being brought here. It's, it's stored in country, and it's de-identified completely. So thank you for asking that.
All right, well, hi, everybody. My name is Dr. Joshua Bress. I'm here with Global Strategies. Thank you so much to Rice360. Yep, thank you so much to Rice360 for the opportunity to come and speak with you today. And special thanks to Zach, who's been so helpful with these slides. By way of introduction, yep, I'm a practicing pediatrician. My clinical work is exclusively with newborn babies. So I'm meeting a lot of babies on day one. I'm meeting a lot of babies like this cute one here on minute one. And we know from the data on the SDGs that we're just not going to make it to that goal of 12 per 1,000 mortality rate in every single country. Why? Why has there been this challenge? The challenge is really in scalability. Highly specialized neonatal intensive care units like the one across the street are just too expensive to scale. There are individual things you can do, interventions. We heard some monitors. But those are really tools, right? Tools whose ability to help any single baby at any moment are really dependent on who's holding them. I saw that experience firsthand, as was mentioned, when I lived in Goma between 2011 and 12. We were working to bring some of the first care for sick and small newborn babies to that still war-torn region. And we started probably like many in this room would start, right? That first cadre of Congolese neonatal nurses, we trained them in neonatal resuscitation. We used the neonatally that was mentioned earlier. And then we equipped them with basic newborn equipment, CPAP machines, O2 sat, glucometers. And we were proud, right? This was a proud moment to bring some of the first neonatal intensive care to a region that has 1 million people and is even today overflowing with refugees. That Congolese team is out there and they're saving hundreds of lives every single year. But we know from the data that the babies who are dying in that unit are actually often born elsewhere. They're transfer cases. They're arriving too sick and way too late for the Congolese team to save. missed opportunities all along the way for earlier care at the point where the child is born. So we did what I think everybody here would do, outreach. The Congolese expert team is going to go out to these sites. They're going to train the facilities that are upstream and try to get ahead of this problem, and it was here. This was the moment in the journey that we hit the challenge that 10 years later brings us to Houston, which was these outlying facilities are fundamentally different. They're different because the nurses who staff them are generalists, sometimes by design, rotating every 3 to 4 months to a new unit. If you were fortunate enough to find a labor nurse, their expertise is really in midwifery and not on the maternal side. So the information that the specialized nurses had to convey was just not easy for the receiving hospital to take and then transform into actions that could actually help a baby. I'll give you an example. You go out, you give a lecture on the importance of neonatal infection, but no, that's not going to result in timely, accurate dosing of ampicillin and gentamicin for those babies who need it. Okay, you can go out and talk about the importance of recognizing danger signs, but it doesn't become like regular vital sign checking, appropriate care escalation. So we were faced with kind of a harsh reality, which was, hey, we were hoping for replication here. We ended up with dilution. Dilution of a center of excellence, and it just had no chance of driving down the mortality. I remember living in Goma at this time. It was like a UN curfew. And I would just come home thinking, I'm out here just like delivering ice on a hot day. And the further we get from this center of excellence, the less this is looking like the original. But now there was some reason to be optimistic, and that was because of the year. The years were early 2010s. Africa was going digital at a rapid pace. Wi-Fi hotspots, cheap locally available tablet computers. A population that was just readily adopting smartphones gave us new ideas. New ideas about how to improve newborn care. And of course, it goes without saying that we were not alone. There was every single person in this room, great groups already bringing important puzzle pieces, especially around neonatal resuscitation. But for us, there was definitely a missing piece. And the missing piece was the nurse. The nurse who we had met, who we had gotten to know so well in Congo. Something that concerns me as a clinician when I go to conferences about neonatal mortality is, where is that nurse positioned? Is that nurse a means to an end, to achieve an international goal, a repository of skills, a technician who can use certain equipment? Or no, people who do this work, we know the nurse is the cure. That's the cure for neonatal mortality. So for us, it's like, okay, well, what would a solution look like? What would a solution that was scalable look like? For us, it was like, well, let's find every nurse and make them more powerful. More powerful in their ability to detect danger signs and act on them, more powerful in appropriately using equipment, more powerful in collecting data that could guide system-level change. We took our inspiration from sort of an unlikely source. Let me make sure this video is going to play, which was Google Maps. And Google Maps, because Google Maps makes drivers more powerful. Okay, so it helps you navigate unfamiliar roads, precise your time of arrival, avoid traffic. And it does that while you still feel like you're the driver. So it doesn't impact your core identity as a driver. Our first move, so we asked ourselves, what would Google Maps for newborn nurses look like? And we tried to build it. Thousands of pages of neonatal guidelines transformed into dynamic, interactive click-through assessments. These PDFs that sat on the shelf became like fast paths through the guidelines. Critically, these align precisely with what the nurse had on hand to use to help the baby. I would say, if you want to know how that's done, maybe come and find me. But in addition, we started asking nurses like this one questions. Just by their reaction, I could tell they had never been asked before. What's the part of your job that you hate the most aside from your salary? Okay. What's the thing that, but not like a bad clinical outcome, but that just like makes you nervous about like going into work? They told us a lot of the stuff you see here. Okay, they hated the neonatal drug dosing. Get the weight, get the milligrams, but also get the milligrams into the milliliters. Take an adult vial size and dilute it. Preterm feeding babies. It sounds so cute. It's algebra. Okay, and people don't like algebra. These comments about the math resonated with me. And they resonated with me for this reason. Have you ever wondered why every medical student in Houston right now does not become a neonatologist? Right? Does not? And that many, it's hard to believe, will have multi-decade careers treating adults when they could be with these cute babies. These are the known pain points of the pediatric clinical rotation. It's why people don't like it. So we thought, okay, we're gonna get this math. In addition, what made them nervous? Presenting to doctors. They hated that. So they wanted a summary that they could read off, they wanted it gamified, but most importantly, they conveyed this sense, like they wanted it like a stethoscope around the neck, something that makes you feel more like a nurse and not less. And that's something that resonated with me as well. We then had to study it. The Novi Guide aligns exactly with the nation's neonatal guidelines. These alignment pieces, I would say if you have questions about how those work, come and find me. So the real question was, would they use it? It aligns with the guidelines. Would they use it? Would they pick it up and adopt it? We studied Novi Guide rigorously, watching people use it. This is with UCSF and IDRC in Uganda, watching people use it, just interviewing them, anonymous surveys, pre and post test evaluations. And yeah, they liked it. They didn't like math, just like they told us. They loved all of these features. But they also had like 1,000 ideas about what they wanted to change. Okay, we didn't know this at the time. We were in the studies. These were like the original Novi Guiders, the early adopters who would drive the innovation forward. These studies kept going. So we proved that the Novi Guiders themselves could download this thing. They could teach other people how to use it. They were often the very best advocates for promoting adoption of this tool, which has always been voluntary use. We continued to drive this down. We proved that the nurses could do it. And in COVID, our work continued to grow as we learned how to do this without ever getting on an airplane. By the time we were done with the studies, we had a great product because we knew nurses would use it voluntarily. We had a way to deliver it. Critically, during those studies, we had met the local leaders who could take Novi Guide and run with it. Novi Guide then scaled rapidly this year to 41 hospitals across Congo and eastern Uganda. It's been used over 120,000 times, but it's growing exponentially. So that growth is probably 125,000 times per year. And I would say every number that I just mentioned, I think we'll double that in 2025. It's just a big scaled intervention. And we were narrowing in on our original goal, something that could reach any place a baby is born. Our inspiration for Google Maps, though, is actually not done delivering. And that's because as we achieved this scale, we were watching people go down these routes. This is not like patient data. It's a guideline, watching people flip through a guideline really, really quickly. We could see where they were going, but we could also see when they hit a block. I'll give you a real world block. Nurse in Uganda wants to prescribe gentamicin, doesn't have it, opens the Novi Guide, calculates the dose, writes the dose down, sends the father to find it, hits stock out in the Novi Guide. At scale, it looks like this. It's almost like futuristic. It's like live stock out reporting of every place this is being used, equipment reporting, all passively. For those in American in the audience, it's like Waze, the app Waze. You see a traffic as you're driving, you hit crash, and now it shows up later to someone to avoid it. In this way, we showed a new way for decision support to work. Yeah, it's always thought of as like a point of care tool for today, but this has applications for tomorrow. Where to send that CPAP machine, where to send those medications, and where to send training. A landmark moment during this journey was Nest 360 and the many people in this room, including many of the African leaders who traveled so far to be here. It's a bold effort to finally solve some of these problems around neonatal equipment. It touches directly on our work. And that is because of this. I can leave the world of algorithms for a second and go to a place I like even more, which is the kitchen. In the kitchen, we often talk in Novi Guide, people want it to work with what they have. Okay, I'll give you an example. I got an oxygen concentrator, no O2 sat monitor. I got an IV, but I'm gonna be counting those drops, and I need a calculator to take those drops and go to mLs per hour. Yeah, we could totally help you with that. But boy, we could cook something much more delicious if you just had some more ingredients. What are the ingredients? It's the CPAP, it's the O2 sat, it's the phototherapy, it's like nest360.org/technology, like all those great tools. We had built our software for the constrained case, humanitarian fragile context, operate to maximize with what you have. There was an opposite case, which is the growth case. Countries are pouring resources into stocking those pantries with equipment. But don't think that if you have a glucometer, you get well-managed baby glucose. Everybody knows that's not true, right? You need to know who to check it on, how to interpret the level, and how to respond. It's the intern core lecture series across the street. The gap is in training. But in 2024, it doesn't need to mean like taking specialists away from their urban areas, traveling out to rural areas, delivering PowerPoints to an audience that may be lovely, but 60% of them will be gone in 4 months to a new job. There's just a way better way to do this. In the Novi Guide, this is like a button. I got a glucometer. I can hit it offline. Now I'm going to get prompted. I put that 2.3 kilo baby in. I'll get prompted to check the glucose. But not only that, the data knows you have a glucometer. It can start to find insights that I think otherwise would be very difficult to find. This is a site in rural Uganda that you just gave a glucometer to. They're using it, but not on Tuesday and Thursday nights. It becomes like a giant quality improvement engine. I'll conclude by saying we've definitely escaped a launch velocity. We're well into orbit. We have US use cases that are providing additional opportunities to sustain and grow. But what's it going to take? 2.5 million newborn deaths that we heard about all week. But I'll throw another number out there, hundreds of millions. That's what you actually have to reach to find those 2.5 million. At Global Strategies, we've articulated a plan that involves 3 next steps. Yesterday in the conference, someone said, if you could put one thing in your hand, what would it be that you don't have right now? For us, another hand. That's what we're looking for, okay? Partners, funders and grantors who are passionate about this. I hope someone in the audience will come and find us, and I'm happy to talk about it. The 3 next steps for us are these. 1, we need to get to a national scale in at least 1 setting so we can demonstrate this value, starting with areas where we already are and expanding to areas where the guidelines we know will be similar. The second, we need to add value to the Novi Guide with obstetrics and young children algorithms. We're well on our way to doing that. Part of it is our users want it, but the other is the implementation costs don't increase with more algorithms, however you deliver this. The last is we need to operationalize Novi Guide's data. 3 types of data that it already collects: stockouts, equipment, and quality improvement data. This is not a data black hole. It's like a data supernova because it's passively generated. We need to support African data teams who can then act on it. As you can tell, we're pretty excited about this work. If it excites you, I hope you'll come and find us. I'm here with my colleague, Anita Gardine, as well, and I look forward to your questions. Thanks.
So my name is Alon, also interested in neonates. I was curious how you manage churn, nurses that just set the device aside and don't really use it, aside from the fact that you have it mapped out. How do you actually get to them and bring them back online?
It's a great question, and the key is the local leadership. I've had this, and I put it in places where people don't use it. I've had it, and I've had it just take off. The difference is always in the local leaders. That's why it's so great that they're all represented here today. They're the ones who can really drive the innovation forward. You need people who are not just leaders, but have the power to go into sites and say, this is important to me, even if it's voluntary. That's how we've done it.
Hi, that was a super interesting, sort of small, detailed question, but I saw that they have tablets. Do they have to use it on the tablets, or does it work if they use their own phone, or what have you found kind of there?
Yeah, it's a great question. So it'll work on any device. Tends to be if you're going to use it offline, which is in most cases in the fragile context for sure, the tablet is a nice way to do it. But yeah, in the US, this is used as a web app, which drives down costs significantly. So that's, I guess, the short answer.
Yeah, thank you very much for a great presentation. And I'm going to ask you the Dragon's Den question. Like, where is the business model in this?
Yeah. It's a great...
What's your valuation? No.
Yeah. It's a great question. And I'll just say for 2 things. One is if I could go back to myself 10 years ago and give myself a piece of advice, it would be to really look at that US use case earlier. But I'm a US clinician, so I'm a,